So I didn't really follow the Lucy Letby case initially. I figured when I heard about it that it was pretty straightforward, albeit horrible. I was postpartum at the time that this made news, and I didn't want to hear about all the awful things she did. As a NICU nurse, I could imagine some of what transpired based on the bits and pieces I saw in the media. She was dubbed England's most prolific child serial killer. Her name was all over headlines with that tagline, and she was seen as the nurse who murdered babies with air embolisms, blunt force trauma, and insulin. She was sentenced to life in prison, so I assumed the evidence was pretty damning. Um, then recently, the Netflix documentary showed up on the front page, and I watch a fair bit of true crime, so I figured I'd give it a watch. I'm also a NICU nurse myself, so I was a little bit curious, I guess. And while I will say I found the documentary to be poorly made, especially with the use of AI to recreate victim families and with some details left seemingly intentionally vague, I must admit it had me pretty curious. I figured either this documentary showed a significant amount of bias, or perhaps the evidence wasn't actually all that damning. And after this release on Netflix, friends began asking me for my take on the whole thing. I've been a NICU nurse for 10 years, so they wanted to know if I thought she was guilty. And the honest answer is, I don't know. But what I do know is that some of the circumstantial evidence used to convict her, as well as some of the claims made against her in the media, are a bit questionable. So let's talk about it. What was deemed an unusual spike in infant deaths at the hospital led to pressure to investigate. There were 17 deaths between 2015 and 2016, and Lucy was set to be on shift for all of them. 8 deaths were in 2015 and 5 were in 2016, between the months of January and June. So, some perspective on if that's a lot. At that same hospital in 2013, there were 2 reported, and in 2014, there were 4 deaths reported. And Lucy started working there in 2011. So it's reported that typically each year, there's between 1 and 4 deaths. So obviously 8 is a pretty big spike. This alone is obviously pretty suspicious, and the chances of someone being on shift for all of these deaths seems improbable. That being said, no formal statistical model was presented in the trial to confirm just how significant the statistic and probability is for that to occur. Additionally, this type of statistic used in evidence might be considered post hoc pattern fitting rather than really proof. It's said that Lucy also frequently picked up extra shifts, but I wasn't able to find how many days per week she typically worked, so I don't know how many shifts she typically picked up extra in comparison with everybody else to see how odd that might be. It's kind of fair to assume she was asked to pick up extra when acuity was higher on the unit, especially since she was regarded as a skilled nurse, and the unit is reported to have had issues with understaffing and lack of experienced nurses, which alone can lead to medical errors. And it is also said that on night shift, it was hard to get a hold of doctors. So, delayed diagnosis and care seem to be common in these cases. When I was reviewing the evaluation by the expert panel that was talked about in the Netflix documentary, a doctor who did the study that was about air embolisms, who was cited by the prosecution team, actually put together a panel because he felt that his study might be misinterpreted. So most of this will be talking about what the expert panel reviewed because that's where more information in detail is made available. Now, due to patient privacy, we don't have all the information, so we're just going to discuss what we have. I'll be comparing some of this with what I know of similar cases just based on my own experience as a nurse. I am not a neonatologist, so again, this discussion will just be based on my own experiences with the limited information provided. I won't be able to draw definitive conclusions about anything, so this, again, just a discussion about what the experts have said, and comparing it with my own personal experience and The entire report hasn't been made public by this expert panel. It's been submitted in an attempt to get Lucy a retrial, so I'm very curious how that will go. So let's get into it. The first baby, referred to in this report as baby 1, was born at 31 weeks and 2 days gestation at 1.6 kilos. He was a multiple, so a twin, and he was delivered by emergency C-section for maternal hypertension. Mom had antiphospholipid syndrome and gestational cholestasis, which I guess wasn't documented in the medical records, which was apparently a reoccurring theme for this hospital, was incomplete medical records. And at birth, baby 1 required resuscitation but stabilized. And then the next day, at 1600 hours, his peripheral IV infiltrated and IV fluids were stopped. They attempted to place an umbilical venous catheter, but it was replaced due to poor positioning. So then a midline or a PICC, I'm unsure which because they just call it a long line here. It's unclear if it's like truly a central line. But it was inserted at about 1900 hours, and then fluids were reinfused at about 2000 hours. And then I guess soon after this is when he suddenly deteriorated. Per the report, he became pale and apneic. He was intubated and received multiple doses of epi. No blood gases were done during this 30 minutes of needing resuscitation. His heart rate dropped. He had some skin discoloration with blotchy patches that were described as being bright pink on a bluey gray background. And the infant did not respond to resuscitation efforts, and care was withdrawn. So, according to the report from the expert panel, the postmortem of baby 1 showed a recent non-occluding thrombus in the liver, which means there was some type of recent thrombotic event. The baby's mom did have that antiphospholipid syndrome, which can pass antibodies to the baby and increase the risk of blood clots. Additionally, in the analysis from the expert panel, they note that the infant had 2 central lines with no fluids running through them for 4 hours. So typically with a central line, you're going to have heparinized fluids running through them to prevent blood clots, and you want to get that home pretty quickly. So to have 2 lines with no fluids running for 4 hours, if those lines were truly just left in place, if they put that umbilical catheter in, got the x-ray, saw that it wasn't where it was supposed to be, and then just left it, that's insane to me that would even happen. So that's kind of what this implies happened, but again, we don't have all the info, so I don't really know if it's true that is what transpired, or if there were they attempted 2 central lines, but the baby didn't get fluids. But if it was left in place for that amount of time, which this report implies is what happened, that increases the risk for a clot to develop at the tip of the catheter. So the expert panel concluded that baby 1 actually appeared to have died from thrombosis, and there was no evidence of air embolism. So this brief explanation alone shows mismanaged care. Also, with the thrombus being in the liver, I'm curious if the misplaced umbilical catheter ended up in the liver, and if so, how long it was actually left in place there. If it was just sitting there with 4 hours with no fluids running through it. So on insertion, the catheter should go from the umbilicus upward through the umbilical vein and into the ductus venosus to the right atrium, IVC junction. But if the catheter enters the left or right portal vein instead of the ductus, it can end up in the liver and cause liver damage or thrombosis. It's not uncommon, even with experienced doctors, for this line to just make its way there. You're putting it in and hoping it goes where you want it to go. So that's why an x-ray is obtained right after insertion to make sure it went where you want it, because it doesn't always go where you want it. A lot of the times it'll end up in the liver. So given the inexperience from staff at this level 2 facility, it seems like there could have been complications related to the umbilical line insertion. Potentially that's where the blood clot came from. I'm not sure. I have a lot of other questions, about that whole case, but that's all the info we have. So to me, it seems reasonable that, yeah, something else definitely could have resulted in that infant's death. Now, the next baby in the report seems to be the one they refer to by the alias of Zoe in the Netflix documentary. This baby was a 37 and 1 week baby girl born at 3.1 kilos who was delivered via emergency C-section for failed induction of labor after prolonged premature rupture of membranes. Her APGARs were 8 and 9, and then at 12 minutes of life, she became pale and floppy and needed respiratory support with a bag and mask. Now, this is where things get a little weird. She was admitted to the NICU 3.5 hours later. So she needed PPV, but then was not actually admitted to the NICU until several hours later. So I'm curious how she was doing after that. Sometimes babies do come out of it quickly. You pop their lungs open, they cry, then they're fine. But that was clearly not the case here. When she arrived at the NICU at that point, she was cold, blue, dusky, and had respiratory distress, polycythemia, and high white blood cell and neutrophil counts. This indicates an infection. It's possible that cold stress also is a component of her condition. The first blood gas was taken 4 hours of birth, and it showed respiratory acidosis. Continuous positive airway pressure, so CPAP, was started nearly 4 hours after birth when she finally got to the NICU. And then she ended up being intubated. It took 3 attempts. And the expert panel states that the chest x-ray showed pneumonia. So I'm not sure if this is based on radiology reports or their review of the x-ray imaging, since respiratory distress syndrome and pneumonia can look similar in babies. There are differences in the x-ray that would indicate pneumonia specifically, but the language in the report does reply that that's the case because they say pretty confidently that it's pneumonia. So assuming that, I'm curious kind of what they did based on this x-ray. I guess the following day, she developed a fever and worsening blood gases that showed increasing metabolic acidosis, which in a newborn can be caused by a variety of things: birth asphyxia, cold stress, hypovolemia, sepsis, congenital heart disease, renal heart disease, lots of things. Here, I would assume it is the result of sepsis. If this were a case study, it would be very straightforward, starting right with the prolonged membrane rupture. That, to me, is the risk factor that immediately makes me worry about infection. The baby's no longer in their little fluid sac protected from the outside world, and some bacteria, even some that's naturally occurring on the skin, like GBS, can be devastating when it causes an infection in newborns. Well, then the next day, this baby was mottled and allegedly had dark brown and black tracking lesions across the trunk and 2 evolving looking patches on the abdomen. So immediately, this has me concerned for sepsis. I'd want a full workup and maybe even a DIC panel if we're having this discoloration. Let's see. She had prolonged coagulation times, raised CRP, and repeated episodes of apnea and desaturation. And she ultimately passed away. So this expert panel believes she went into DIC, which caused the discoloration, and they concluded that baby 4 died of systemic sepsis, pneumonia, and DIC, and that there was no evidence of air embolism. They cite delays in care and improper care as factors in her death. I find it very interesting that they claim this infant was stable prior to Lucy's involvement. To me, it seems like that is an inappropriate analysis of this infant's condition, and that this inadequate assessment may have contributed to her rapid decline. It appears no one intervened when there were several red flags that, when coupled with maternal history, should have prompted concern for sepsis pretty early on. So I have a lot of questions here. Were blood cultures sent? What did they do with the x-ray results? Did they make any changes based on that? Did they start antibiotics? And if so, when? Mom didn't receive antibiotics before delivery. Was mom GBS positive? I'm assuming no, since they didn't give her penicillin before the delivery. Did they test for torch infections? It sounds like she deteriorated or started to deteriorate well before an IV would have even been placed, since it took 3.5 hours for her to come to the NICU. She did not come to the NICU looking good. She didn't come over there for simple respiratory distress or TTHN, anything like that. She came over there looking pretty bad after delivery. So I'm curious how much other information on these infants was presented in court, because it just seems like we're missing a lot of information here, or this was just really bad care. Based on this information, I can't imagine how they had enough evidence to support the claim that an intentional air embolism caused her death. Now, there were 3 cases that the jury reached a unanimous decision on. That wasn't one of them. But 2 of them did involve the administration of insulin. So let's talk about that. I actually have so many questions about the insulin accusations. The first thing is, how do they know, if this did happen, that it was Lucy? When medications are pulled or requested from pharmacy, there are usually procedures in place to prevent errors for high-risk medications. In my experience, you have to pull it from a Pyxis, or you personally have to request it from a pharmacy through like an online format that is documented and trackable. I wouldn't be able to do either of these things, though, if the medication was not ordered. So how did Lucy allegedly access this insulin without some type of paper trail? And if it was documented that it was her, when did she pull it? Was it for a different patient? How much was she given? So a statement from a pharmacy technician who worked at Countess of Chester since the 90s stated that in a review of her records, it shows that in 2014, 3 vials of insulin were ordered to the NICU, 6 in 2015, and 2 in 2016. This, to me, seems like a lot of insulin for a level 2 unit to even need. In the NICUs I've worked in, we're never given a large vial of insulin, but we do have our own NICU pharmacist who basically prepares it for us. And it's either given as like a very small IV bolus, a very, very tiny amount, or we give it on a drip. And even then, the syringes are not big. They don't give us a ton. And it's often, if we even have a drip, it's barely enough to prime our med line and still like have enough to set the syringe on the pump for the amount. So, one of the theories discussed was how insulin can stick to tubing, which is true. We prime our insulin in the tubing and let it sit before we give it, if we're going to give it as a drip, because it just like does weird things with the plastic. So it's also given typically or verified with another nurse. Like it's one of those meds that's always co-signed. So I'm just wondering how this would have happened without somebody else being involved in some capacity, having somebody else even just see the insulin. So perhaps this hospital was dispensing large vials, and that's not something you would typically have to waste. So I guess maybe she pocketed it if that's what happened. It's just a hard scenario to imagine given how many constraints there typically are around meds, both due to like risk of error as well as costs. The hospital doesn't want people stealing medication. So while we do not have very much public information about the baby who did die, allegedly this way, Letby was also accused of attempting to murder this baby's twin, who was identified as baby 6 in the expert panel's report. So we can kind of review that. So this baby, again, was one that she was accused of poisoning with insulin, but he survived. But this would have been around the same time since he was a twin to the other baby. I'm also going to attach the link to the report that was made public in the description if you want to review it yourself in more detail. So that link will be in the description below. So baby 6 was a 29 and 5-week infant born at 1.4 kilograms via emergency C-section for absent end diastolic flow. Honestly, he's a pretty good size considering he was a multiple and also had impaired blood flow from the placenta. The expert panel did call him borderline IUGR. According to the report, he had mild respiratory distress syndrome, which is pretty expected for a baby that gestation. And it says he also had hyperglycemia that required insulin treatment. So this surprised me just because in my experience working in a level 3 NICU, we really don't frequently give insulin. We obviously give it, but it's just not super often that it's needed. We usually will give a low dextrose IV fluid, like 5% dextrose to lower the GIR, the glucose infusion rate. And then if that doesn't work, then we would consider insulin. So if this baby was requiring insulin, it kind of makes me wonder why. Was the hyperglycemia a result of stress or sepsis? This doesn't sound like a stable infant who inexplicably deteriorated. Early hyperglycemia is a risk factor for increased mortality in preterm infants, and I typically have only seen it prolonged to a capacity of needing insulin in very critically ill babies. So I guess a nurse practitioner from the hospital said they would give the baby insulin for 2 consecutive blood glucose levels of 12 or higher, which is equivalent to like 216 milligrams per deciliter if you're more used to that as a member. But it's unclear what other interventions, if any, would be tried first. So that could just be differences in procedure. I'm just explaining kind of what I'm more used to and what I've seen work. We typically try low dextrose fluids first. So I guess on August 5th, he developed sepsis and hypoglycemia and was treated with antibiotics and IV glucose infusion. And then over the next 17 hours, his blood sugar remained low, despite repeated boluses of 10% dextrose. And it's wild to me that for that long, they didn't switch to a higher concentration of dextrose. You can give 12.5% dextrose through a peripheral line. To give higher than that, you'd want a central line. I guess at some point his long IV line was noticed to have infiltrated with extensive swelling and induration of the right groin, thigh, and leg, according to the panel report. So the IV must have probably been bad for a while for it to be such extensive swelling throughout the leg. And then IV fluids were stopped from 10 to 12. So while a new line was inserted. So that's 2 hours without IV fluids. Then at 12, the IV bag was changed. And then again at 1900 hours, the dextrose infusion was increased to 15%, and then the hypoglycemia resolved. It's wild to me that it took so long to start D15 with a central line. They could have gone to D20. It was alleged that baby 6 was given exogenous insulin through the infusion bag because there was a prolonged period of hypoglycemia. His blood glucose allegedly rose from 1.3 to 2.4 when his dextrose infusion stopped. But this conflicts, I guess, with what time the blood sugars were actually documented to have been drawn. So that's another interesting thing too. And then obviously it rose at 1900 when they gave him D15. So the reason they think he was given exogenous insulin is because he had a high insulin but low C-peptide level in his lab work. The panel opinion is that the hypoglycemia started with sepsis, and it was prolonged because the IV infiltrated for several hours. So, I mean, yeah, that would contribute to it, and also only giving D10. So he should have gotten a higher concentration of dextrose earlier, according to the expert panel. I mean, I agree. It's wild to me that he wasn't. I understand if he didn't have a central line that 12.5 is really the highest you can go, but it sounds like he did. They also claim that the repeated D10 boluses can worsen it because it causes surges of blood sugar, which trigger surges of insulin secretion, creating like a yo-yo pattern. I'm not super familiar with this because we did give D10 boluses pretty frequently, and then we would switch to a higher concentration of dextrose on our IV fluids. But the blood sugar, allegedly, like they claimed it rose when the fluid stopped. So that's pretty damning when you say it like that. However, according to the expert panel report, which I'm assuming has medical records, the blood sugar was 1.4 at 11:46, and the 2.4 was measured after 12 when the IV fluid was restarted. So, I don't know. So those infusion bags were prepared in the pharmacy, stored in the unit, and changed at 12. Multiple infusion bags would have to be contaminated if there was insulin poisoning. And then obviously it rose at 1900 hours, not only because they changed the bag, which they're claiming was poisoned, but also because the dextrose was increased to 15%. So, according to the expert panel, they conclude that baby 6 had the prolonged hypoglycemia because of sepsis, prematurity, lack of IV glucose, and that that his insulin and C-peptide ratio does not necessarily prove exogenous insulin was used. The expert panel does claim they are within norm for preterm infants, but I don't know enough about that, and also it sounds like that's a hard claim to make. However, it's worth noting that this test that was used is not considered reliable enough to be used as evidence, and it's something that would be checked with other lab work, and it wasn't. So I don't know. It's really hard to say with 100% certainty that that's accurate, even if most of the time they are. And then in another case, kind of similar to this, the infant was put on D15 after Lucy left and continued having persistent hypoglycemia well into the next day. So the bag was started when she wasn't even there. So it's just interesting. There were other cases of suspicious hypoglycemia on the unit that Lucy wasn't charged with a crime for. So it's just curious. I do have several questions. One being, does the pharmacy compound their own IV fluids? Could there have been a mistake? We have had situations where bags that were supposed to be D10 were actually D5. The reason it was caught was because two babies in a similar area of our unit started having low blood sugar at the same time, and they had not had any blood sugar problems prior. So the charge nurse suggested they change the bags. There was an internal investigation, and they found out it was an error. So it's possible that an error occurred in pharmacy, depending on their protocols. This wasn't some tiny rural hospital with limited resources. I mean, it's a 600-bed hospital, so I imagine they have a big pharmacy, but I don't know if the NICU had their own designated pharmacy the way that we do, so I'm just not sure. And then another case in which the jury reached a unanimous decision was that of a baby with bruising on the liver, which was described as being caused by blunt force trauma. Now, this one I can't speak on as I haven't really experienced a baby with this problem. However, it seems to be one that has sparked a lot of debate, and one of the theories that a physician hit the liver with a needle was apparently discussed at length in the courtroom. He attempted to aspirate from the abdomen during resuscitation efforts, so they theorized that perhaps he accidentally nicked the liver with this needle, but then others say that this type of injury wasn't indicative of that, so I don't really know. But this baby was born via C-section and was one of 3 multiples. It said that the babies were delivered quickly, 1 minute apart, which made the panel speculate the possibility of birth trauma. Aside from not passing meconium for 36 hours and then deteriorating over the course of a few days, this case didn't seem all that complicated, so it's unclear to me in the descriptions of what exactly happened, other than a slow bleed from the liver that then escalated to, massive blood loss into the abdomen, causing the infant to deteriorate. One doctor described the type of liver trauma as being comparable to a motor vehicle accident. Again, it's said by the expert panel that this can happen from a traumatic delivery, though a traumatic delivery wasn't documented. A rapid delivery can result in birth trauma, but it's just hard to speak on this without knowing more about this case. The expert panel concluded the death may not have been intentional. I'm curious if Lucy was there for all the days that the baby was there. I don't know. I can't weigh in heavily on this one, but obviously there's a lot of information we're missing given that the jury unanimously decided she was guilty for this case, which to me sounds like potentially one of the worst ones if it was truly this significant blunt force trauma. It's just hard for me to imagine somebody doing that at work. I don't know. I hope that she didn't, because for all of these, but I don't know. Really hard to think about. One incident that immediately made me question the legitimacy of the accusation was the incident involving a baby who was born at 25 weeks gestation. A doctor allegedly witnessed her at the infant's bedside while the infant's nurse was on a break. At this time, he states the infant's oxygen level was low and the alarm was silenced. The doctor stated that a 25-week baby just lays there, and the only explanation for his tube being dislodged was intentional extubation. Now, this claim is wild to make, and it tells me that this doctor is not really familiar with these types of patients. Unfortunately, it's very easy and common for little babies to extubate themselves. The ET tubes often, at least where I work, are held on with just tape. So at a facility that shouldn't even have had babies this age, I do imagine they have issues related to the lack of staff experience and knowledge as well as resources. We have all sorts of positioners and tips and tricks that we use to keep these babies intubated. Um, we also have very experienced RTs taping the tape. So I don't know. And these babies are also often in like a humidified isolette, so that can help, um, or that can prevent the tape from sticking, depending on what kind of tape you're using. There's just so many things. Now, the expert panel stated that the infant had an air leak and was intubated with a 2O size ET tube. The sensor didn't show any color change, so the fact that they even checked that tells me the ET tube was still somewhat in place, and they said Lucy didn't have her hands in the bed with the baby. So the fact that they even checked, the tube wasn't just laying next to the baby, it was still down the kid's throat. So I don't know, like, it just seems wild to claim she must have done something to this tube for it to be dislodged. These kids can literally just like flail their arm in the air or get agitated because they're often intubated without any type of sedation. Um, so they can move around and dislodge the tube, especially if it wasn't really in place. And I'm not even fully convinced it was dislodged with the air leak and the size of the tube. It's possible the color change didn't show because of poor circulation or baby was barely intubated. I guess, according to the expert panel, they re-intubated with a larger tube. This to me, I don't know, it all sounds like a regular Tuesday. We often pause monitors to watch and see if they resolve their desaturation on their own. We'll increase their FiO2 and see if it resolves. Sometimes these babies will vagal themselves when they move around or try to poop, and they have a temporary dip in their heart rate or oxygen. It's just really, really, really common with these babies, especially depending on like their ventilation. Are their vent settings appropriate for them? There's so many questions I have here. And it's just like for this to be even brought up as questionable, or I don't know, seems like a big accusation to make by somebody who clearly does not understand the common issues with these babies. So if we called for assistance every time their oxygen dipped, nothing would ever get done. Half the time, that's why they're there. So I'm just curious what vent settings this kid on. Was it appropriate? Do they even have high frequency ventilation, or is it all mechanical ventilation? Given that that infant shouldn't have been in this facility at all. So who knows? In another case, where Lucy was accused of pushing too much air into a feeding tube, as well as overfeeding, the expert panel believes there's sufficient evidence to suggest it could have been enterovirus. The baby was vomiting and had watery diarrhea, as well as a history of extreme prematurity. She was born at 23 weeks gestation at a different hospital and transferred to Countess of Chester Hospital on high flow when she was older. She fell ill with the vomiting, watery stools, went apneic. When these babies who are micropreemies get sick, it's usually pretty serious for a period of time. So she was ventilated, which can also push air into your belly. And she was ill for about 7 days, which is how long it takes for enterovirus to run its course. So it seems like a hop, skip, and a jump to suggest that overfeeding in an attempt to murder the infant caused all of this, when, I mean, the kid would have just thrown up, So there was another case with an intubated baby with thick ET tube secretions and a positive sputum culture that passed away as well. They claimed this baby died as a result of an air embolism. The baby was never treated for their respiratory infection, and they claimed that Lucy pushed air into the feeding tube, but the baby had to be bagged multiple times, which pushes air into the abdomen, and if you don't pull it off, obviously they're going to have distension and loopy bowels. The x-rays took place after the ventilation happened, which is when I'm sure they saw air in the abdomen. We typically will try and aspirate air off through a large French orogastric tube, whether it be a feeding tube or a POBL, typically a feeding tube. If they already have a feeding tube in place, we'll just try and use that, pop the syringe on and try and pull air back. But sometimes, depending on the placement, it's hard to get air out. It just seems within the realm of possibility that these babies died from inadequate care. If these babies died as a result of systemic issues, then the scapegoating of Lucy Letby is actually a terrifying precedent. If Lucy truly did not murder these babies, then, I mean, there needs to be some search for accountability for what caused this. Now, if she did murder them, then systems should have been in place earlier to detect concerning trends and more appropriately document and investigate them so that we had more definitive evidence available. Because for there to be even a shadow of a doubt is horrifying. So those are, the case studies essentially on the infants that she was accused of harming. So now I want to discuss some of the I can't talk, I'm sorry. Now I want to discuss some of the aspects of this case that I thought were just really weird. The first being that Lucy kept her report sheets in a box under her bed. Many people claimed these were her souvenirs as a serial killer, but she kept report sheets from hundreds of babies, so I don't necessarily think that's true. It was not only a weird thing to do, but it's also a patient privacy violation, which is why I think she lied about it. She said she forgot and took them home, something that most nurses have accidentally done. I've done it before, more than once. We're prone to putting things in our pockets than leaving. Bottom line, she shouldn't have had them. I don't know why she kept them. I suspect Lucy might have been a little odd and had some quirks. Not that that excuses it. I just also don't think this necessarily makes her guilty of killing all these babies. The most serial killery part of the documentary to me was the post-it notes. They were creepy. I'll display them here. They're hard to read, but obviously some of the bits and pieces referred to her harming babies, saying she was evil, but also there's conflicting statements on there too, but they're kind of scattered. It's claimed in the documentary that this was part of some sort of therapy and that she was writing out how she was made to feel, which I can see based on kind of what was said. She probably did feel, partially to blame, like maybe she missed something or did something wrong. There were probably a lot of emotions kind of going on here, and like I can see it being either way. Or she was a serial killer and this is the ramblings of a crazy person or a horrible evil person. I'm not trying to say she's innocent. I truly don't know. I don't know. We are assuming it is that she is admitting she's evil, or at least they were assuming that to convict her and have this as evidence. It just doesn't look like something a sane person would do. And so I do honestly think that these post-it notes probably had a large influence on how she was perceived by the jury. Now, this part might get me in trouble with some of you, but I don't think it was that weird that she searched the families on Facebook or sent sympathy cards. I think she was nosy. I know a lot of colleagues whose interest gets the better of them, and for one reason or another, they have been curious about a former patient or how they're doing, and they search them on Facebook when some people keep in touch. I've had families add me on social media after they have been discharged. Now, very rarely, I don't like to cross boundaries, and I'm not very big on social media. So, but many people do it in the NICU. I feel like you develop really personal relationships with families in the NICU. And in instances where the baby doesn't survive, you might be one of the only other people who's ever even met the baby, depending on the circumstances. So it can be really lonely for some of these parents who lose their baby. It's really sad. I've been invited to many newborn funerals. It's common for an invitation to be posted in the NICU break room. It's also not that weird to talk to your coworkers, especially after particularly hard shifts. I think the way that this was presented made it seem much weirder than it really is. The reality is we deal with dead babies and it's horrible, and our friends and family outside of this don't want to talk about it. I mean, it's horrible. It makes people sad. All of this being said, I do think there needs to be a retrial. The evidence is all circumstantial, and in my mind makes it hard to say without a shadow of a doubt that she killed any of these patients. The death stopping after she left can also be explained by the unit downgrading to a level 1. Also, during this time, it is documented that a manager had reported issues with being able to transport patients out to the higher level care facilities just due to a lack of beds. So they were taking care of babies they had no business taking care of without enough staff. So I think it's just, it's really hard in this to say that, yeah, she definitively did these horrible things rather than, hey, maybe it's a systemic issue that needs to be investigated on a larger scale. I don't know. And I think that regardless of whether or not you think she's guilty, if you are a nurse, you need to pay attention to how your actions may be perceived by the court of public opinion in a trial. You need to be mindful of your internet and social media searches and how they might appear to somebody who doesn't do your job. I was thinking about that as I was searching information about this case. I was like, oh my gosh, like this probably looks shady. What am I gonna do? Say, hey, yeah, it was for this YouTube video I'm making? Like, just seems weird. You should be mindful also of how well you document concerning incidents. Make sure you aren't pulling out medication for other people unless you personally will be there when it's given. Report concerning changes to physicians, and if you cannot reach a doctor or get a response, you need to document that too so that it does not fall back on you. And you should escalate that to somebody else in the hospital, whether it be the charge nurse, a manager, house supervisor. You know, get your witnesses that you did try and do something in a timely manner so that this doesn't fall back on you. Because when they look at a paper trail from a case that happened years ago and nobody remembers exactly what happens, that documentation is going to be what saves you. It'll say, hey, I tried to do this. So I know it's hard when you're like short-staffed and you're busy, but that's when it's really important to say, hey, I tried to do this. Now, don't try and throw people under the bus. Just make it very straightforward. Attempted to reach so-and-so at this time, message left, whatever. If it's urgent, escalate it to the house soup. Say that you contacted them too. Just make that trail. And if you work on a unit where doctors and nurses do not have a good, collaborative, professional relationship, then you need to be very mindful of what risks that carries. If you're on a unit where doctors are routinely blaming nurses for things, just know that one day that might be a really big deal. And just be very careful about how you document things. And if you have verbal orders, no, like you need a paper trail. That's all I'm saying. Protect yourself. I'm actually surprised by how the expert panels didn't elaborate on nursing care and nurses' roles. I'm surprised at like the lack of processes and procedures for some of the events described in this case, like the insulin administration. That wasn't clearly explained. So make sure you know your hospital's policies and that you follow them. If you don't have policies that protect you, definitely consider advocating for some. Don't override medication. Look at the case of Redonda Vaught. You know, don't let that be you. Don't be doing anything that makes you look like you're up to no good because it all can and will be held against you. So maybe maybe Lucy did do what they accused her of doing. And if that's the case, it's a good thing she's, you know, rotting in prison. But if she didn't, that's terrifying too. And that would mean that justice wasn't truly brought for these sweet, innocent babies who unfortunately didn't get the care that they needed. The whole thing, obviously, is really awful, no matter what, you know, for the families, for these babies.